Thank you very much, Alice, for that kind introduction. It really is a huge honor for me to be here. And I am so grateful for the Simons Foundation and its Safari program, and for everything that you do to support research and improve our understanding of autism. I was especially honored to be invited by Dr. Reichart to speak to you about the epidemiology of autism spectrum disorder and focus specifically on the role of social and cultural factors. My own perspective on this is, I'm sure, shaped by my training at Columbia, where I had an opportunity to work with and be mentored by leading thinkers in the epidemiology of developmental disabilities and in psychiatric epidemiology. And this was during a period when autism was barely on the horizon in the way that it is today. My overall thesis, I think, for this talk is that despite all of the work we've done, we still don't really have a good understanding of what is causing the rise in autism prevalence over the years. Is it due to improved awareness or changes in the diagnostic criteria or something in the environment? Probably all of the above and other things as well. But I think I've come to conclude that regardless of what's driving it, and I'll discuss some of the trends and some of the clues we have from epidemiologic findings, I think we have to come to terms with the fact that it is much more prevalent than we are prepared for, really. And as a society, we're not prepared to provide the services that are needed to all of the children and more than children, growing numbers of adolescents and adults with autism to serve their needs. And so I think in this, I think and one of the points I want to make is that I think we can learn something from a related developmental disability, intellectual disabilities, which has really merged, a transition from thinking about it as a disorder to a disability. And I'll talk about that in a little bit of what we might learn from that for autism. So, but before I want to I'm sure that not everybody here is very familiar with epidemiology as a field, so I like to begin by just defining this field and commenting on why we even do epidemiologic studies of autism. The most common definition is that this is the study of the frequency and distribution of diseases or disabilities or other health outcomes in populations. And we emphasize populations for three reasons at least. One is that it has to do with selection bias. So if instead of studying a disorder in the population, we just look at individuals who come to a particular clinic or a volunteer sample or a convenience sample or something like that, we might get the impression, for example, that most of the people with autism are from very affluent families, or they're by and large white, that kind of thing. Whereas if we look in the population overall, we get a very different perspective. And this can be important when you're looking at the causes and the mechanisms underlying. There can be biases. Another reason we focus on populations is that if we want to test hypotheses about the risk factors for diseases, we can use the source population from which the cases came as like a readily available, unbiased control group for testing hypotheses about causes and things like that. And then a third reason for focusing on the population has to do with really epidemiology evolved during the 17th and 18th centuries, and the idea of something called the common good. It's not just every individual out for themselves, but how can we use science and knowledge to improve the population overall? And sometimes what's best for the population might be different from what's best for the individuals. Also, that's linked to this utilitarian idea, which is that we have a limited resources that we can invest in research and in health. How can we invest it in a way that will create the greatest benefit with these limited resources? So this is another reason why we focus in public health on the population. Now, this slide shows it really summarizes the prevalence studies of autism that have been conducted around the world from the first studies in the 1960s. The very first study was in England, through 2009. And you can see that over this time period, there was a huge increase in prevalence based on epidemiologic studies where efforts were made to go in the population and count every person affected. There's been almost a 50 to 100-fold increase in the prevalence over the years, even because it's continued to increase after 2009. And we don't really know to what extent this is due to, during the same time period there were changes in the diagnostic criteria as well, and undoubtedly some of the rise is due to that. But we don't fully understand this. But it is important, I think, to realize that the rise in autism has not occurred in a vacuum. And during this same period, this chart is from a chapter by Neil Halfon and Paul Newacek on the percentage of children in the US population who have a disability from 1960 up through 2009. And you can see during the same period where the prevalence of autism has increased, the percentage of children with any kind of disability has increased from less than 2% in 1960 to over 8% today. And the other point made in this article was that a lot of this increase could be linked to different public policies and social and laws even, and availability of different services. They also point out that during this period when the prevalence has increased, the proportion of disabilities that are classified as mental rather than physical also increased tremendously. So this is sort of the overall context during which we've seen an increase in autism. Another perspective on the rise in the number of children with autism can be seen in the public education data. And what's shown here is the number of children in the US between 1992 and 2002 who received special education under an autism category. So it's not really epidemiologic data, but these are some counts that we have in the population. And it's been pointed out that it's not that there were so few children with autism in 1992, but this was the first year that autism was a category for receiving special ed in the country. And so what we saw was that the numbers, as the category and the services became available in schools to serve children with autism, every year the numbers went up, and they've continued to go up. It's even much higher today. But these kind of data generated a lot of concern, actually, and wondering, is there an epidemic or what's going on? And it was based largely on those school data that Congress in 2000 passed in the Children's Health Act. They called upon CDC to begin doing surveillance of autism. Before that time, the Center for Disease Control and Prevention had been monitoring other developmental disabilities, but they hadn't been doing autism at all. It just wasn't in their radar. So after 2000, they put together something called the Autism and Developmental Disabilities Monitoring Network, which works at different sites across the country and tries to get a sense of what the actual prevalence among 8-year-old children is in these sites. And we've been doing this over time using the same methodology and the same diagnostic criteria, DSM-4, between 2000 and 2010. We're currently working on the 2012, and then we'll be using both DSM-5 and DSM-4 for a few years after that so that we can compare. And just to tell you briefly the methodology for the ADAM network, what we do is this is just an example from one of our surveillance years. It changes sometimes over time, the actual numbers, but in 2008, there were over 300,000 8-year-old children in these populations under surveillance. That's about almost 10% of 8-year-old children in the US. And any child who had a referral for a developmental assessment for a concern about any kind of disability, or who received special education services any time before they turned 9 years old, we reviewed their records from multiple sources. So we reviewed records for over 38,000 children, and then there's a protocol for abstracting any records that are relevant to making an autism diagnosis. And from that, culling those records, we abstracted the records for over 6,000 children. And then a team of clinician reviewers reviews these abstracted records following a standard protocol. And from this sample, they identified 3,800 children who met DSM-4 criteria for an autism disorder. That's basic methodology. And this slide summarizes the numbers that we've gotten since we've been doing this surveillance from 2000 to 2010. And you can see that every year, pretty much, the prevalence has increased. So in 2000 and 2002, about 1 in 150 children were identified as having autism. And by 2010, it's 1 in 68, which corresponds to nearly 1.5% of children, 8-year-old children, meeting criteria for an autism disorder. And when we monitor over time what we've seen in terms of the sex ratio, just about every study that's ever been done of autism will show excess of males, and we certainly have found this in the ADAM data over time. But one of the things we've seen is an increase. In the very earlier epidemiologic studies, the ratio was closer to 3 or 4 boys for every girl. And during this time period when we've seen an overall increase in prevalence, we've also seen an increase in the sex ratio, and we don't know why this is. Okay.
And so what they started calling autism later on was identifying people with a higher intellectual ability who are autistic, and therefore the ratio is.
This fits what I'm going to talk about soon as I bring up some information about the intellectual functioning. Yes?
I was just wondering in the last slide, was that for people with like more extreme autism, or was it 1 out of 68 had any type?
Any type. This surveillance is a good question. The question is it any type of autism? And the surveillance system has no way of classifying by severity. So we've been doing essentially ASD, anyone on the spectrum, since 2000. It's a broader definition. Thank you. And then we've also been monitoring by race and ethnicity over the same period. And what you can see here, in red, the line in red is the prevalence in white non-Hispanic children. And in blue, it's black non-Hispanic, and then the yellow is Hispanic children. And what you can see is that there's a disparity in the prevalence of autism in the US based on these data, and it's been persistent over time. In each group, we're seeing the prevalence is rising, but it's rising similar in all of them, and so the disparity has continued. And another analysis we've been doing with which we've done with these data is to try to get an idea of what is the likely impact of transitioning to DSM-5 from DSM-4 on the prevalence of autism. There have been a number of clinical studies, and they have a huge range. There are some studies that were suggesting that more than 80% of children served in certain clinics who were diagnosed with autism under DSM-4 would no longer be eligible or wouldn't receive that diagnosis anyway if they were newly seen using DSM-5. And then there were other studies that said the impact wouldn't be that great. So we wanted to see, looking in the population overall, what kind of impact might we have. So what we did was we retrospectively applied DSM-5 criteria to 2 years in the database, 2006 and 2008. And what we found was that this study, too, was led by Matt Maynor, was that there would be an impact if we just applied those criteria retrospectively of about a 19% reduction in prevalence in our prevalence estimates. And as you might expect, those that have more of the symptoms of autism under the and more criteria met under DSM-4 would be less likely to sort of lose this diagnosis under DSM-5. But we would also caution that we're just doing this retrospectively based on records that were collected under DSM-4. And it's quite likely that moving forward with new training and clinicians documenting behaviors in a new era, that we wouldn't see this. So I think this is kind of a maximum impact that we might expect on the prevalence. And it's certainly not, we're not going to go back to the levels seen in the 1960s. It's really a pretty modest impact that we would expect. Other analyses we've done with our ADAM data are to look at some risk factors for autism and whether we can get some clarity from the large population data that you might not have gotten from other studies. And one of the things we looked at was the relationship between maternal and paternal age. The literature has been mixed on this. There are a lot of studies, some studies showing that it's the father's age. With increasing father's age, the risk of autism increases. Other studies suggest it's mother's age. But it's very difficult to disentangle these two because they're highly correlated. So you need a very large sample. And there was a study by Krohn using the Kaiser Permanente data from California, which suggested it's both parents' age. When you control for one, you still see the effect of the other, and vice versa. So we set out to try to replicate and try to see whether we would support one or the other. And what we found was that it was very consistent with what Krohn had found. Both the mother's age and the father's age increases the risk of autism. And they occur independently, so it's a kind of an additive effect. We also found that there was an association with the birth order. So firstborn children were at greatest risk. And when you put these three risk factors together, they're additive, so that if a firstborn child is born to both parents being older, their risk of autism is 8 times greater than a later born child from younger parents. So it's quite a significant impact, actually, on the risk of autism. We were hoping that we would find it was just one parent's age or the other, because that might help narrow the search for mechanisms. But it appears that there's such a range of mechanisms associated with autism, and other evidence supports this as well. The association with paternal age is certainly consistent with the findings of de novo mutations, which increase in frequency as men age, and also have been found to be associated with autism. And there are a number of implications, I think, from these parental age findings, both public health implications and possible implications for the etiology of autism. Since there's basically been a sea change in the age of parenting since the 1970s in the US and many other countries. Since 1970, there's been almost a 5-year increase in the average age of mothers having their first child. And the proportion of births that are born to mothers over the age of 35 has tripled since the 1980. Now we think that this change in parental age probably only is has a small impact on the risk, on the rise in autism prevalence that we've seen. In other words, as marked as it is, it's not steep enough to account for the 50-fold increase that we've seen in the prevalence of autism. But I think this finding also has some clues to etiology. I mentioned the de novo mutations. This paternal age finding is certainly consistent with findings there. But also it suggests a role for chromosomal changes that increase as mother's age, and with a range of pregnancy complications that it also increase with maternal age, and that we're also finding to be associated with autism. We're consistently finding preterm birth to be another risk factor for autism in these recent years. Yes, question?
Let's see if I can do this. I was wondering if you can deconvolve the parental age from the birth order. I mean, obviously they're also...
Yeah, they're definitely linked.
Right.
So thank you. Birth order and parental age, as parents age, the likelihood that it's a later birth increases. So we can adjust for that statistically. And actually the effect of parental age increases when you control for birth order. Increases slightly. So they are correlated, but you can control for them statistically. And that's where we found they each had an independent effect, an additive effect on risk.
So is there a correlation with, for example, things like in vitro fertilization? I mean, where older parents often have
in vitro fertilization. We have not studied that because we don't have any data on that, but there are some groups out actively looking into this. And the last time I reviewed the data, the evidence was somewhat mixed, but that's definitely concern that there might be an association there. Yes?
In the previous slide, you showed the different, actually prior to that, you showed, I guess it was a few slides. Sorry. You showed different rates for different racial and ethnic groups in the U.S., but they seem to track in the same manner. So what I'm curious is, could you be sure that the rates really are different in those groups, or it's just that they're over or underdiagnosed
Yeah.
in some groups
Yeah.
relative to others?
The question is whether these differences are really true or are they just differences in identification. And I'm going to come to that because I think you're onto something. I think it's very likely that we're under-identifying, and I'll give you some more evidence for that just now. Yeah, so let's move along. In fact, I'll talk about it now because I'm going to talk about, I want to talk a little bit about the association between socioeconomic status and the risk of autism. The idea,
That you
yeah. Oh, I missed this.
you
Thank you.
mentioned that birth order
Oops.
might be due to stoppage,
Yeah,
which I think that's a good point because it surely is a factor there.
okay.
The
Stoppage is the idea that once a couple has one child with autism or another disability, they might be less likely to have another child, and then overall, children with autism would be more likely to have a lower birth order. And you know, that's been suggested, and I think it's quite likely. We didn't have any way to evaluate that, but a recent study was published out of California where they were able to link SIBShips on a very large population, and what they found was that within the first few years after the birth of the child with the autism diagnosis, there was no difference. The fertility was the same in families with an autistic child with autism and those without. But after 2 or 3 years, it diverged. And families with a child with autism were 30% less likely to have another child. So fitting exactly what you said. Thank you. Yes?
Could it be that it's certain time periods of parental age that they could have an autistic child?
Oh, could there?
Could it be that that there are certain times in an adult person's life that they are more likely to have an autistic child then?
Well, we have shown that as they age, they're more likely to. And we don't really understand that. Another reason could be just if the parent themselves is on the spectrum in some way, they might have later parenting for that reason, for their own social issues and things like that. So there could be multiple reasons. But that's pretty firm. The birth order thing seems to be a separate issue and yes, it's less likely that they would be a firstborn when they're later. But as I mentioned, the rates of first births to older parents is also increasing. Thank you, though, for that. I did want to mention this other perinatal risk factor, which is birth spacing. This was something we hadn't intended to look at all, but there was a study by Czeslaw-Postava published in 2011 using data from California from the Developmental Disabilities data set, and they showed that if the interval between one birth and the conception of the next child was less than 12 months, that's a relatively short interval, the risk of autism was 3 times higher than if it was a longer interval. And this was the first report of that. We thought one of the things that epidemiologists try to do, because we can't do experimental studies very often, we have to use observational data. So we try to replicate, and if we don't really begin to believe something until we've seen it several times, and in different data sets, trying different things. And so we wanted to see if we could replicate it. And I didn't expect that we would be able to. But we were able to do it with the ADAM data. We actually looked, and we found, too, that a short interval was associated with increased risk of autism in our data. But we found this U-shaped association, so that birth intervals of 5 years or longer were also associated with an increased risk. And I think other groups are looking at this now, and so the jury's kind of out as to whether it's U-shaped or not. But as far as the short interval goes now, there have been 4 studies published that suggest this, and there's a number of biological mechanisms that it points to as well. So one of the reasons that we're excited about this finding is that it's one of the few risk factors in autism that we've been able to identify in epidemiologic studies that we might be able to modify. There's actually public health recommendations to aim for birth intervals or interpregnancy intervals of at least 18 months. But we might suggest it should be closer to 2 years. We don't really know what the optimal birth interval is, but it's probably, at least for preventing autism, we might aim to 2 years might be a good suggestion. Now, I did want to turn to this relationship between social class and autism. The idea has been around since the very first descriptions of autism by Connor in 1943, that autism is somehow more common in wealthy families or highly educated parents. In fact, he says here, in describing these cases of autism, his first descriptions, he said there's one other very interesting common denominator in the backgrounds of these children. They all come from highly intelligent families. And this idea kind of permeated the early studies of autism. In fact, the early epidemiologic studies all looked at parental occupation and education and did report some relationship with autism risk. But then in 1980, Lorna Wing published this paper where she questioned the whole idea. And just to quote her, she said, it remains true that a knowledgeable and determined parent of an autistic child is more likely to obtain an informed diagnosis. So she made the case that that autism is just as common across all of the social classes. It's just that children without the resources are not going to get the accurate diagnosis, and that would explain the entire association. And so after this paper, there was not a thing in the literature about relationship between autism and parental occupation or social class for many years. In fact, in review articles, if they mentioned social class at all, it was just to say there is no relationship, But there really was no data that they showed. They just, and then we thought, why not, with our ADAM data from Wisconsin, we should at least begin to look at this. And we did this study and found actually a remarkable dose-response relationship. With increasing social class, the prevalence of autism increased in the population. And this, just to point out, this pattern is the exact opposite of what you'd see for any other developmental disabilities. If there's a relationship with social class at all, it's the other way, where children in poverty have much higher prevalence of the disorders. And then later we were able to repeat this study using the full ADAM data, where we have a very diverse population. And we could stratify by race and ethnicity. And what we found was we saw the same pattern, basically, in every racial and ethnic group that we could look at, increasing risk with increasing social class. And yes, question?
Excuse me. Does this relate to the age of the parents? Longer
It's a good question. Does it relate to the age of the parents? Yeah, it's a very good question. Unfortunately, the data set that we can look at parental age with, the denominator there are birth certificates, and we don't have a social class. The only indicator we have is mother's education, but we weren't able to do it in this way. But it does appear that that once you control for mother's education, when you put the variables in the data set together, it's the parental age that seem to have a stronger impact and they are related. So it's an open question. Yes.
I noticed that that Hispanics have less prevalence. Is that because of less studies, less people in the studies, or just is that do Hispanic people, is there less of a prevalence, or is that just a statistical thing?
I think it's neither of those quite. I think, and I'm going to speak to this as well because there is a study, but it's not that there's fewer Hispanic people, because this adjusts for the number of Hispanic people in the population. But I do think it is under identification, most likely, and probably language barriers and things like that, but we'll discuss.
So, like, they're undiagnosed.
Yeah, and if they weren't evaluated, we have no way to pick them up in the surveillance system. So, yes.
In the map you showed earlier, so that was that's the main set of ADAM data, correct? That's where you get all your
Yes.
data from?
Yeah.
So it won't account for any of the cultural diversity in the entire country, of course.
It
so
isn't,
this is
yeah,
kind of
and
biased.
unfortunately, it's not a representative. It's not representative of the full diversity in the country, but it is population-based, and there is quite a bit of diversity in it. So that's why we can stratify by these factors, but it's limited. But I think one of the take-home messages from this is that and it really clarifies that racial and ethnic difference in prevalence, because we can see that it's not that there's any less autism, say, among black non-Hispanic children of high SES, their numbers are up there with everyone else. It's just that there are more children living in poverty who are black, and so that brings down their overall prevalence. And I think what's really driving the racial and ethnic differences, especially between black and white children, is the relationship with social class. And there are a lot of implications of this finding, and I want to summarize them here. One is that if we assume that Lorna Wing is correct, and this difference by social class is all due to ascertainment bias, and we're just not able to count the children in poverty, it would suggest that there are significant disparities in access to autism diagnosis and services across the country. It would also suggest that our numbers, 1 in 68, are really a pretty severe underestimate of the prevalence of autism, and that if we actually counted all of the children with autism, then the prevalence would even be higher. So whichever way it is, it's, I think, an important finding, especially in light of the cost of autism. Autism is probably the most expensive form of developmental disability, both for the diagnostic workup and for providing services. It is the most expensive form of special education, for example. And the standard treatments of intensive behavioral interventions cost a minimum of $50,000 a year, and usually it's actually quite a bit more than that at the end of the day. So if we think about the fact that we're underestimating and underserving children with autism and the costs involved, it's really staggering, and I think this is one of the things that the field of autism needs to come to terms with, and it should be a priority for us to address the issue and find lower cost ways of serving the population and more efficient ways as well. I want to point out that there's 2 papers published relatively recently which suggest that, again, that Lorna Wing was correct in that it's probably due to under-ascertainment, the patterns that we're seeing in this country. And one is a study from Sweden, where they have very much less socioeconomic disparity anyway that we have. And they also have universal access to health care. And they tried to replicate our study and found no excess prevalence in the higher social classes. In fact, it was slightly in the other direction. So that was one finding out there. Another is a study from Sandra Magana, who looked at, she studied Hispanic and then white non-Hispanic families who had a child with autism, a fairly large sample. And she compared the differences in terms of when they got their diagnosis and their access to services. And what she found was that there were systematic barriers all along. The children with autism in the Hispanic families, by and large, didn't get their diagnosis until after the age of 8 years. And this precluded any access to early intervention services that we know are so important. So it was she actually described the linguistic barriers and the financial and cultural barriers that prevent this. So I think these 2 studies kind of support, or at least provide some evidence of under-identification. But I think that we should at least keep an open mind to the possibility that there are socioeconomic differences in autism in its occurrence. We don't know. I mean, there might be something about the physical or social environment of children from highly educated families that increases their risk of autism. There have been a number of suggested pathways, but we don't know. But if I had to bet on it, I would go with the under-identification hypothesis at this point. And then it's also possible that there's clinician bias that's contributing to the disparity. Kukuro did a study where they sent vignettes, descriptions of children with autism, basically, with and without autism, to clinicians around the country. And they randomly varied the race and ethnicity and the social class, so the parental education of the children. And what they found was that there was no racial bias, like clinicians were no more likely to call it autism if the child was white or black, but there was a social class difference, and it was pretty pronounced. So it's possible that clinicians trained in Connor's criteria and reading the journals, you know, there is this sort of mental bias in the way that they diagnose. I want to just mention that there's other studies from the ADAM network, and one of the things that we're monitoring is the age at diagnosis. And it turns out, in order to be identified in the ADAM network as having autism, you don't have had to have a previous diagnosis of autism, just documentation in your records of behaviors that add up to autism by this clinician review. And in fact, 27% of the children in one previous study year, this was 2002, in this sample didn't have a previous autism diagnosis. And Paul Shattuck did this analysis where he looked at what predicted the median age, what was the median age at first diagnosis, and what predicted it. And what he found too is that the median age was over 5 years, which is, again, missed the whole opportunity for early intervention. And we've been monitoring this number since 2002 and really seen very little change in it over time. So on that indicator, as the prevalence is increasing, we're not bringing down the median age, at least we haven't yet, at which the child receives a diagnosis. But I think there's some real reasons for optimism on this, and there's several things that have happened that we wouldn't have picked up, identified through our surveillance data through 2010. And one of them is the policy now for universal screening for autism, part of the American Academy of Pediatrics recommendation from 2007. This is something that isn't universally applied yet in the country, but it's growing. It's a growing movement, and more children are being screened for autism at their routine well-child visits. It's likely that possible that we could detect in the future a reduction in the age with this policy in place. Also, with universal health care that has no exclusions for pre-existing conditions. That wasn't true in the previous years when we've been doing surveillance. It's possible that this could change. There's mandatory insurance coverage for evidence-based autism services in a growing number of states. And as those catch on, it's possible too that we will see improvements both in the age at identification and the access and a reduction in the disparities of who has access. There's also been obviously more awareness, improved training of clinicians, and better diagnostic tools. All of these things, I think, should help in the future with reducing the disparities. Now, I want to talk a little bit about the relationship between autism and intellectual disability, which was brought up just before. One of the explanations out there for what could be driving the rise in autism is this idea of diagnostic substitution, which is that in the past we used to call it intellectual disability or mental retardation in the past, and now more and more of the same children we're giving them the label of autism. So this is one of the explanations out there, and there's certainly a lot of evidence of that. What's shown here is data from the U.S. overall, children receiving special education services for autism in yellow and intellectual disability, and you can see just at the same period where autism is rising, intellectual disability has declined. And now this chart is hard to follow, but it's showing basically the same thing. These are data from the Social Security insurance program, which provides insurance for children with income supplementation for children with disabilities in the U.S. And from 1990 here down to 2010. And in blue, this is the proportion of all the children receiving SSI for mental disorders. This is the proportion that were receiving it for intellectual disability. And that has just plummeted during this time period. And at the same time, autism and ADHD have emerged to fill in the gap. So we're seeing even and there are other data sets as well that show this drop in intellectual disability, rise in autism during this period. Also, around the world, this slide summarizes the world evidence on, it's basically similar to the earlier chart I showed of the rising prevalence in autism around the world. But what's shown here is in red, it's the prevalence of autism without intellectual disability. So these are children who have average IQ and autism. And in green, it's the prevalence of autism with intellectual disability. And what you can see is over these years where the prevalence overall has increased, it's mainly in those with average intelligence, without intellectual disability. And so what we've seen overall, before 2000, studies pretty consistently showed that about a third of children with autism had IQs in the normal or average range. But after 2000, when we've had this increase in prevalence, the proportion with IQs above 70 has increased, so it's now about 2/3. And we've even seen this in our ADAM data just since 2000. What's shown here is the reduction over time in the percentage of children who had IQs below 70. It was nearly 50% in 2000, and it's dropped down to about 30%. Now, there's a number of theories about the relationship between intellectual disability and autism, and I'm grateful to George Anderson for bringing this to my attention, because I hadn't really thought of it. But I had always thought that they were associated because due to some underlying pathology, and depending on the timing of the brain insult or the extent or location of it, a child might have just intellectual disability or intellectual disability and autism. There's also a strong co-occurrence with seizure disorders and cerebral palsy. So which combination you get will depend on the nature of the brain injury. But it's also been suggested that the intellectual disability itself could be the cause of autism. If it's severe enough, it could impair the social communication and be associated with the repetitive behaviors. We don't really know. It's been further suggested that it's the underlying autism is the cause of this association, and that one suggestion is just that the impairments in social interaction and the restricted behaviors and interests actually interfere with brain development, because so much of cognitive development and intellectual development occurs as a result of interaction between a child and their social environment. And so if that interaction is blocked, their intellectual development won't occur. So that's another theory. And then there's this idea that it's not really that autism causes low intelligence, but it causes low measured intelligence. Because of the impairments in social interaction, our measures of IQ in children with autism may not be very accurate. And this is kind of an idea that I think could be underlying these relationships we're seeing and the changes we're seeing over time. In one idea is that, and certainly actually before I talk about this, because this doesn't really support it, but if you think about the interventions that are evidence-based and shown to be improved outcomes for children with autism, the ABA and early Denver model and things like that, their main outcome measure is IQ. It's not the autism behaviors. And so I think one explanation given is that by treating the autism behaviors and managing them, that you can get a better measure of their real IQ, and then we discover that they actually didn't have intellectual disability. That could be what's accounting for this change over time. I don't know. But another sort of clue from our ADAM data is that it doesn't necessarily support this, but if that were true, we might see the blue line decline over time. So in other words, this is the prevalence in the population of autism with intellectual disability as defined by IQ below 70. That has not declined over time. It's just that the prevalence among the average IQ children is what's increased so dramatically. And so I think the jury is still out on this relationship between autism and intellectual disability, but it's an interesting area of investigation and much to be known. I want to talk a little bit about this conceptualization of intellectual disability and some lessons we might learn from it about autism going forward and controlling autism. But basically, the intellectual disability is seen as, it's definitely a dimensional diagnosis. We categorize it, but it's based on this underlying idea that IQ is normally distributed in the population and adaptive behavior as well. And so intellectual disability is defined as both adaptive functioning and IQ that is more than 2 standard deviations below the mean. So in other words, that would correspond to an IQ of below 70. So that is one way that we define intellectual disability. But a way to think about it too is that it's partly that the IQ is distributed normally in the population. So by definition, about 2% of children will score below that cutoff. A little less than that will score below the cutoff for both IQ and adaptive behavior. But there's also like a whole separate distribution, and that's what's shown here in green. And these are children with actual brain injuries or damage, neurologic disorders that result in intellectual disability, and they too have a distribution. Some of them function like some children with Down syndrome may have an IQ above 70 at points in their lives. But I bring this up because in the field of intellectual disability, there's been huge progress in reducing that small distribution. In other words, we've actually figured out how to prevent a lot of the causes of intellectual disability in the population. Through newborn screening and treatment for PKU is just an example. We've drastically reduced the frequency of brain infections in children and the intellectual impairment that results from that. We've gotten lead out of the environment. Even the early intervention programs for Head Start. There's been a lot of reason to think that this decline in intellectual disability is not just due to diagnostic substitution, but there's actually been a reduction in the frequency of intellectual disability in the population. It's a possibility. There's also this idea called the Flynn effect, which is the idea that IQ itself, even ignoring the separate distribution for children with abnormal brain development, the IQ itself distribution has been shifting over time, about 3 points every decade. So we're basically getting smarter as a population. Now I know they recalculate the norms periodically, but they don't do it every year. And so it's possible that intellectual disability is declining just because our average intelligence is improving over time, and that's been suggested. And whether that has any relationship to autism and the proportion of children with autism with low IQ, we don't know. But I think the field of autism could learn something from intellectual disability. And one of the things is that there was a shift many years ago in intellectual disability when they changed the name from mental retardation to intellectual disability, to thinking about it not as a disorder necessarily only, I mean it is, but not just as something we need to fix, but also many children, when we haven't been able to prevent the disorder, we can work on improving the functional outcomes and improving their lifetime transition into adulthood and participation in society. And so that's kind of this distinction between disorder and disability. This table sort of summarizes the progression in terminology for intellectual disability in the DSM-4, the American Association for Intellectual and Developmental Disabilities, and then the DSM-5. And you can see that when they got rid of the terminology, it used to be called mental retardation. It was considered a disorder. It was defined purely in terms of IQ, below a certain IQ threshold. But the newer definitions of intellectual disability really emphasize this concept of disability. And in fact, there was a law published and passed recently in the US saying that we had to go in and change the terminology. And it's interesting that in DSM-5, I think they wanted to use the word intellectual developmental disorder. They put that in parentheses in DSM-5 for intellectual disability. But they're mandated by law to use the term intellectual disability because of the disability rights movement, really, and the advocacy calling for that, for thinking about it more. We've seen that in it was the American Association for Intellectual Disabilities that pushed to incorporate adaptive behavior, to go beyond just the impairment, the IQ, and incorporate adaptive behavior into the definition itself. And that has been caught on and adopted by DSM-5. Also, in terms of classifying severity, the intellectual disability is now entirely classified by the level of support needed, not by IQ. So it could be mild, moderate, severe, profound. That whole idea has been incorporated into DSM-5 as well, including for autism. So there's a severity classification in autism in DSM-5 for autism that is levels of support needed. And so that's coming from this disability movement anyway. There are other distinctions between disorder and disability. I don't want to dwell on these too much, but one of them, in the disorder framework, these are rare conditions, whereas disability is thought of as much more common. Actually, most of us would experience disability at some time in our lives if we live long enough. And so given that, there's more of a focus on these issues of functioning and participation in society once you take that disability perspective. And this is consistent with an international movement to use the International Classification of Functioning, which embraces this disability perspective on all kinds of disorders. Now, I've tried to put autism within this ICF framework, and it's difficult because basically the ICF disability framework classifies these 3 levels: impairment, functional activities, and participation in society. And they have measures for each of these. But in autism, if you look at the literature, almost everything focuses on impairment. And I know, there's just as much scientific research to be done on the functional side of things and the participation in society once we take a broader perspective. But up to now, the research in autism is almost entirely focused on the impairment. What's causing it? How can we fix it? And this movement to move to more of a disability perspective than disorder is very consistent as well with the international conventions, the International Conventions on the Rights of the Child and the International Convention on the Rights of People with Disabilities, which is a whole paradigm shift to thinking much more in terms of a human rights approach to disability. And I think I can see the evidence that this is in terms of trends, it's affecting the autism world as well. There's more and more papers now focusing on functional outcomes in children with autism and eventually participation in society. This Special ISTERN is a fabulous example. This is an organization that set as its goal to find jobs for, I think it's 1 million people with autism around the world as they transition into adulthood. And I want to just then conclude, because I think I'm out of time. Just in conclusion, I think epidemiologic studies show that an increasing prevalence of autism. We don't fully understand why, but we're finding that more than 1%, some studies even find more than 2% of children meet autism criteria in the population. And our service delivery system is really not prepared to meet this need with the tools that we currently have available. I think future epidemiologic studies need to shift to more of a disability perspective and monitor not only the disorder in the population, but also the functional status. Not all the 2% of children meeting criteria actually are disabled, maybe, and they might have different needs. We need to focus more on participation and transition to adulthood, as well as disparities in the access to services. And I think once we do this, we'll be able to really achieve what epidemiology is intended to do, which is to find ways to make the greatest impact that we can on the population overall, not just on the selected few who are able to get the diagnosis. So thank you very much.